This is a video demonstrating arthroscopic repair of double radial tears of the lateral meniscus. The patient is a 16-year-old male three-sport high school athlete. He presented with acute left knee pain after a pole vaulting accident, in which he fell down approximately 14 feet and twisted his left knee on impact. He had immediate pain and swelling, initially managed with a hinge knee brace. On exam, he had a positive Lockman with no appreciable endpoint. His MCL opened 3 to 4 millimeters at 20 degrees of flexion, but had a firm endpoint. His x-rays were negative. MRI revealed lateral meniscus radial tear, as demonstrated here, as well as extrusion of the lateral meniscus. MRI can also be helpful in demonstrating posterior root tears, here on sagittal and coronal views. The patient also had an ACL rupture. There was also an MCL tear. The lateral compartment is assessed during the initial arthroscopic diagnostic exam, here demonstrating a tear of the posterior root as well as a meniscal body radial tear. Devascularized tissue is first debrided from meniscal tear edges. A 3.5 millimeter full radius shaver as well as a double-sided rasp is helpful to create bleeding edges. We then introduce zone-specific cannulas to place 2O non-absorbable sutures in a horizontal mattress fashion to reduce the tear anatomically. We recommend anywhere from 5 to 8 total sutures. It is of utmost importance to ensure an adequate reduction at the meniscal-capsular junction to maximize healing potential. Utilizing this technique, all sutures are tied over the capsule through a small posterior lateral incision just anterior to the fibular collateral ligament. Attention is then turned to the posterior root. We use an Arthrex meniscus root repair tibial guide, which has a marking hook, seen here. Place the hook at the posterior aspect of the tibial plateau, and using the distance markings, determine the anatomic position of the posterior root. You can then set the guide at that distance for accurate transtibial drilling to the posterior root footprint. Introduce the 6 millimeter flip cutter. Remove the drill guide and flip the cutter. Retro drill back to a depth of 10 millimeters, and then remove the drill. Introduce a shuttle suture or a looped shuttle wire through the tunnel. Through the ipsilateral portal, place 2 to 3 cinch sutures, which are O fiber wire or O tiger wire sutures. We utilize a self-retrieving suture passer, such as a knee scorpion device from Arthrex. We demonstrate the use of 3 sutures in this case. However, 2 cinch sutures are adequate. Once the cinch sutures are in place, retrieve the suture loop through the inferior lateral portal. Pass all the sutures through the loop and pull them down through the tibial tunnel. As you tension the sutures, you can see that the posterior root is pulled down into the socket in an anatomic position. Cycle the knee to remove as much creep as possible and secure the sutures with a swivel lock anchor on the anterior tibia, just distal to where the sutures exited the tunnel. Here's an example of the final repair.